This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. I'm really excited about our current headache series going on right now. Today's topic is advances in headache science and classification. With me to discuss is Peter Goadsby, Professor of Neurology at University of California, Los Angeles, and Professor of Neurology and Director of the NIHR Clinical Research Facility in King's College, London. So, Peter, thank you so much for being on our Neurology podcast.
Well, thank you for asking me.
There is no better person to come on here and update neurologists on headache science and classification, partly because you're the chair of the classification committee, but in addition, your wealth of knowledge.
Well, that's very kind of you, yes.
So can you just give us a little summary of how it's kind of laid out and how it can be useful for the average clinical neurologist?
I think most clinical neurologists who see someone with headache are, to some extent, knowing it or not knowing it, using the classification, because the classification is very clinical. Most neurologists who see someone with headache and they think is migraine, for example, ask them if they're sensitive to light or they've got nausea. And happily, if they read the classification, they'll see that's one of the things that we suggest people ask about. So I think most neurologists practicing, if they looked at the classification, wouldn't find it odd. In fact, I think it's probably the more specialised you get, the more worried you get about the detail. For the card-carrying practical neurologist, I think much of what's written is relatively straightforward at a top line. So the way we divide it up is in three. We divide it into the primary headache disorders, the secondary headache disorders, and then the neuralgias. And the primary headache disorders, migraine, tension type headache, the trigeminal autonomic cephalalgias, cluster headache, a series of other headaches, things like primary stabbing headache, primary sex headache, your daily persistent headache. And what it's useful for I think the general neurologist, and I might say it's available free of charge on the International Headache Society's website, romping good 200-page read, is simply to remind themselves about features of perhaps the odder things they might see and features of the thing that's sitting in front of them and how it fits into the classification if there's any diagnostic issues. The other thing to say is that all of the recent clinical trial work, all the clinical science work that's going on is done on the basis of this classification system. So it's useful in the broader sense because one's applying all the translational and clinical trial work that we've seen done in the last decade to the person sitting in front of you.
So to that point, some criticism about other classification systems as well is that it's not biologically driven enough. Doesn't include biomarkers, imaging biomarkers. And so what do you say about that?
Well, I completely agree. It's not biologically driven enough. And that's to do with the lack of biomarkers, lack of imaging or other sorts, say bloodborne biomarkers that we have in primary headache disorders. I don't think that's a criticism of using it. I see that as a challenge moving forward to understand the disorders better in terms of the biology. I mean, at the end of the day, most people who come along, particularly to general neurologists complaining of headache, in the main, if they have a primary headache disorder, they'll reveal that simply by a history. I think it emphasises the value of the neurologist over, in general terms, the value of investigation. But I certainly accept that we would be better if we could underpin the classification with more biology.
I love that. And that means that we can't get rid of the neurologist quite yet. We cannot be replaced.
Oh, exactly. The complaint to do more tests is great, but the neurologist is already a high-value person who, with their training and their knowledge, can ask questions, make a diagnosis, make a plan of treatment, and in the headache disorders, make many people considerably improve. I think we overrate tests and underrate good clinicians.
But I think what we can say is there is a lot in the classification, and it in many ways does follow biology and even clinical prognosis. If you take new daily persistent headache, for example, and while we all have seen patients that have done remarkably well, there's something about a patient that when their headache comes about within a day and persists for months to years at a time, that might be a more difficult to treat patient.
Oh, yes, I completely agree with you. When you look at the new daily persistent headache, if you look at making the diagnosis, let's mention something rare because we're neurologists, chronic paroxysmal hemicrania. That diagnosis will respond to indomethacin. It will continue to respond to indomethacin. We don't understand why it's indomethacin, but we can, with the stroke of our pen or the click on the mouse, really improve the patient's quality of life by getting a diagnosis and applying the appropriate treatment. And we do have some of these things have yielded up. Familial hemiplegic migraine, for example, the genotypes of most of that are now well described. So we're there, but we've got there a little. I wouldn't try and defend that we don't need an enormous amount of information about biology to round this out over time.
And I find some of the more useful information actually is not in the diagnostic criteria, but in the comments. For example, you have the prodrome or premonitory symptoms in the comments of migraine. And when we're thinking about people with migraine disease, really is a condition that is quite variable in individuals and even within the same person. And some of that includes those different phases of that disorder.
Yes, at one level, the classification has the advantage of simplicity. And we talk about migraine, we'll talk about migraine, using nausea, light sound sensitivity, throbbing, for example. But that simplicity belies the complexity of the disorder. There's an argument, one group in the world of classification, minimalists, what's the least you can have to capture the most? Another group might say, well, there's a face validity question. If the majority of our patients, perhaps even more than have nausea, have fatigue or cognitive impairment, why are we not mentioning that as core criteria? I'm not advocating one or the other as chair. I'm sitting on the fence a little bit. I think it's a worthy discussion. The migraine criteria have not changed since they were first promulgated, you might say, in 1988. And we've learned a lot more about the biology, for example, of the premonitory phase with functional imaging. We've now even learned in recent times that we can treat the premonitory or prodromal phase with GPANs. So I think that if you understand the biology of something and you can treat it explicitly, it's perhaps time to think about the extent to which that needs to be incorporated in the criteria without messing things up, it has to be said. I'm very sensitive to the fact that these criteria have been quite successful. I mean, when you look at it since they were introduced slightly before the triptan era. They've given us triptans, they've given us the oral GPANs, they've given us the monoclonal antibodies, they've enabled us to flesh out pretty much everything we've done in the last 30 years. And so they've been rather robust and they've allowed us to do it all over the world. I think that's a measure of the strength.
I think you raise very valid points because neck pain, for example, I think I've read somewhere that about 70% of people with migraine may have neck pain, and that's far more common than nausea.
Yes. And of course, nausea happens in other things. So it's not as though nausea is a migraine thing, it's neck pain or it's fatigue or concentration problems in the context of the constellation of symptoms. It doesn't, just because cognitive dysfunction occurs in other things, doesn't mean it can't be part of migraine if you indeed accept that phenomenon for something like nausea.
So I think one area that is kind of up for discussion is this chronic versus episodic, and that goes for tension type headache, migraine, other chronic daily headache syndromes. And there's been a push to, I think in other fields too, like in hypertension, in obesity, to kind of go to even like a mild cognitive impairment to try and capture things earlier, diagnose things earlier, because disability and disease and impairment can start earlier. So this idea of 15 headache days or more, what are your thoughts on this distinction?
At the last meeting of the classification committee, we talked explicitly about this, the chronic migraine problem, you might say, the issue of the demarcation between chronic migraine and episodic migraine, and indeed, what's the utility of the diagnostic label chronic migraine. When you think about the demarcation we use, we say if you've got 15 days or more, we'll call it chronic, and if you've got less than 15, we'll call it episodic. It's absolutely arbitrary. Certainly people with more migraine have greater disability. Certainly people with less have less. There is a lot of argument about the number, and I've seen people write 6, and I've seen people write 8, and I've seen people write 12. But as soon as you write a number, if you write 8, then are people with 7 all of a sudden to be left out? That's complex. And this is something we're actively discussing. We don't have an absolute policy that we've developed as yet. And I'm sure whatever we say, someone's not going to like it. For myself, I think that migraine's migraine. And there's the top line diagnosis. What do you have? You have migraine. What's the impact of your migraine? That will be determined by a range of things. And one of them is the frequency of the disease. Another one is the severity of the attack. Another one is the reliability of the treatments that you might use for the acute attack. I think we need to take a much broader, I dare say patient-centric view of how we want to define and use these terminologies. I think the simple frequency delimiter is not serving patients very well, and I think it doesn't serve clinicians terribly well either.
And it makes it even more complicated. I think it was a patient that said, isn't all migraine chronic?
If you inherit the genetic tendency and you carry it with you your entire life, if you're talking about the underlying disease propensity, then that must be chronic in any way that you look at it. And simply by using the manifestation and the terminology, it is rather messy. We've let ourselves get into this messy position. It has implications because in many parts of the world, that distinction is used, for example, for availability of the new classes of medications. And if we change that, we have to be mindful of the implications of change because the ICHD is used everywhere. It's one of the few things where you can get pretty much everyone to agree that I know of that's practicing headache medicine.
One thing I find interesting, I had a patient that I saw last week who was diagnosed with chronic tension type headache and came for a second opinion. And after communicating with him, I changed his diagnosis to chronic migraine because while he wasn't wearing dark glasses, I said, well, if you had a preference, and then he said, yeah, okay, well, I would want to be away from the fluorescent light. I asked him about sound. It doesn't bother me. He said, yeah, but if you had a preference, if you had one of the more severe headaches that you would treat, well, yeah, of course, quiet. And I was at least able to get 1 or 2 episodes at the onset of his headache problem of some GI distress with headaches that he was going to the emergency room for while in Italy on vacation. And so I think some of this is maybe even an artifact of how we elicit these sensitivities.
Oh, no doubt. The thing you get from a headache fellowship, if you train in headache, is not really about how many milligrams of a GPAN you should give, but they're about the nuances of taking good history and really understanding what the person is saying. If I take the phrase, not really, when someone says, if you ask them a question and they say, are you sensitive to light? And they'll say, not really. Now, what many people are meaning by that is, I am a little bit, but I don't really want you to be bothered by it. Or some people just mean, I'm not really taking an interest in your question, or I'm not concentrating. There's a whole range of what that means. And as I often say to patients, not really is not an answer. So you're going to have to give me yes or no because we're not doing not really. That means you have to have the time. You have to hone your clinical skills. But again, it illustrates the value of the neurologist taking a history over just picking up an app or picking up something and reading it and, tapping on the app and trying to get a diagnosis that way.
Even though I've spent enough time with you that I think I can design you in an app.
The problem is the person, do they understand the question the app's asking? You must have had experience where you ask someone a question and they give you an answer, but you get an impression that they're not quite getting the question you're asking them. You have to hone your questioning. History taking is not some dumb thing where you just read off a series of questionnaires. That is not history taking. History taking is a skill. It requires years of practice. You're never really good at it at the start. I mean, I still, I'll talk to someone and I'll think to myself, I could have done that better. I re-emphasize it's the great value of the clinical neurologist, the ability to take a history, not order some test.
Why don't we talk a little bit about some of the recent collaborations that have been done to move the classification forward? I know there's been some work in orofacial pain and also for vestibular migraine that has been ongoing for some time.
On the orofacial pain side, we've had good collaboration that Anna May, who's on the classification committee and is the most recent previous editor of Cephalalgia, has worked with the pain folk. Our classification as it appears in the International Classification of Headache Disorders and the text in their classification are the same because they're the same conditions. Go figure. That's an important thing, I think, for making sure that folks in the orofacial pain space and the headache space are at least coming to broadly similar conclusions. Now, they might have in terms of diagnosis, they might have a different view on the mechanistic side about how pathophysiology arrives, but we're starting to talk the same language. That's really important for patients. At the end of the day, classification, everything we're talking about is to make things better for the patients with these disorders. We all get to the same point, then we can start to think about the same sort of medicines. Now, on the vestibular migraine side, it's quite a vexed question. We discussed that again at the last classification committee. There's two sides. The diagnosis has the disadvantage of extracting out vestibular symptoms and calling them another form of sensory sensitivity. So we don't call out photophobia and refer to photic migraine, or phonophobia and call it phonic migraine. That's an issue at one side. On the other side, to be clinically pragmatic, vestibular symptoms are often assessed in non-neurology symptoms, audiover settings, audiovestibular, otolaryngology. Perhaps having criteria for vestibular migraine will improve communication between areas of speciality, will identify a group of people who will do better if the underlying biology being migrainous is recognised. So we're thinking quite hard about how to properly bring that classification into the main section of the committee, and there's a stream of work in that area. For myself, again, if you take the history, vertigo is extraordinarily common in migraine, and not everyone with that you'd necessarily want to label as vestibular migraine. However, there's a group of people for which the vertigo is the presenting symptom, it's the main disabling symptom, using terminology that might irritate some, but on the other side of it makes sense to patients. Now, at the end of the day, you want people to understand what we're saying. We want to be able to communicate with them that we've heard them and we're understanding their problem and we're trying to improve it. So I think it's quite an important area of collaboration. We certainly have active collaborations with neuroetologists and audiovestibular folks to be able to sharpen this up.
There was a conference, one of the ENT conferences in Miami Beach around where I work, and one of the colleagues in that department came up to me. She's like, it was all vestibular migraine. And so it is very important to have that collaboration.
I wouldn't like to see every person who's got vertigo dumped into a basket and called vestibular migraine. It requires a little bit of thought. That's something that wouldn't be helpful. But on the other side of it, unquestionably, there's a group of people who are labelled with other things at the moment who have a migrainous problem, many of which we're seeing respond very nicely to the CGRP. So you could argue much about much, but if you can start to improve people while you're having the argument, this is a useful outcome.
So why don't we talk a little bit more about some of the controversies in the classification?
Haven't we been talking about those?
Well, some priorities may be a better way to phrase it. Menstrually related migraine, similar to the vestibular migraine, where it's a trigger that's associated with a type of migraine. So where are we in getting that from the appendix, where it still need to validate to actually as something that we can really just use?
Folks are always welcome to use the appendix criteria. There's nothing embarrassing or wrong with that. I mean, they're put there for use and validation. They're put there for both. And the committee is well seized of the importance of menstrually related migraines. No doubt that there are women who are very bothered by attacks that are occurring around their menses. There are clinical trials that have been that have looked at and ongoingly looking at this question. I think it's simply a matter of getting the criteria slightly sharpened up to get them into the main section. Don't think anyone in the committee's terribly opposed to that.
And of course, we need to talk about medication overuse headache.
We talked about it in terms of nomenclature. So I'm aware that there are many who find patients and even physicians who find the terminology pejorative and unhelpful. Is terminological change desirable? The present criteria aren't pragmatic. I think committee would go on record to say that. And we recognise that we need to think about the terminology because the current terminology is stigmatising, but not universally stigmatising. I think that's important. If you go around the committee and you go around the world, you won't find every population group using the classification finding the criteria stigmatized. And that's quite variable. It's important to remember we're a global society. This is a global illness. We have to face it in a global way. The other bigger problem in many ways, well, is the implication for the global burden of disease. That's a technical problem. And then there's the issue of the medication overuse versus medication overuse headache. And what does that mean? Does everyone who takes a certain number of medicines get headache? No. Does everyone who taking a certain number of acute medicines with headache, is that causing it? No. Is it making it worse for some? I'd say yes. How do you draw that distinction? Difficult. The new medicines have changed that, I think, somewhat. It's pretty clear from the data that for most folks with medication, I'll put in inverted commas, air quotes, you might say medication overuse headache could get on a Gepant or a CGRP monoclonal, they will improve. Now, is that because there was no medication overuse-driven headache, or is it because those medicines are capable of reversing that biology? They're all not understood problems, and we want to put together a discussion paper around the issues. I don't think it's just a question of saying, oh, we'll just change it from medication overuse to some other raspberry headache, some other terminology, because the underlying construct has problems. Once you dissect apart the underlying construct, I think it'll become a lot easier to find a terminology that fits the construction and, as they say, is fit for purpose. So that's really a watch this space. Committee's well aware of it. We want to do something about it.
Great. So I love the idea of, as we think about something that might be more appropriate, let it be driven by a biology. For example, I always have to remind myself of medication overuse when I read these translational research papers, and I'm like, oh, okay, there's biology there, yes. There's some genetic predisposition there, yes. But oftentimes in my clinic, what I see is poorly treated migraine in particular that drives this, and you get someone on a good preventive therapy, and within a week, they're not needing acute treatments anymore, and that's pretty remarkable.
I think modern practice has changed the emphasis here quite a lot. The fact that we have a class of small molecule drugs, the Gepants, you can use for acute treatment or use for prevention, that pretty clearly don't cause medication overuse problems, tells you that we need to pause and really think about the terminology, as you say, in a biological context.
So can you give us a little bit of insights into potential changes? I know it's all potential changes for the next classification 4.
We're thinking quite hard about what to do with current tension type headache criteria. We're thinking very hard about the demarcation between chronic and episodic migraine and whether it's relevant at all. Medication overuse we've talked about. We're thinking quite hard about I think it's a thorny issue of primary and secondary headache disorders when there's a phenotypic overlap. So very typically the post-traumatic headache and migraine users as an example, the person who has a head injury, even a mild head injury, and then has a headache that if you didn't know they had a head injury, you'd be forgiven for thinking that they had migraine. How you think about that interaction both biologically and from a classification point of view, we're quite interested in input from folks about these sorts of things, because I think that the practice of headache is widespread and many clinicians will have views about what needs to be changed. I think taking away oral ear, AURAL, fullness out of the cranial autonomic features in section 3, I was just going to say it, wash my mouth out, but I think it was a mistake, because it's very common and it helps diagnostically, it helps get folks in the right management direction. So small things like that we'll be certainly looking very, very hard at.
And you mentioned that there is going to be an opportunity to give feedback or discussion, an open discussion.
We'd like to give folks an opportunity to have input. Each time the classification committee has a meeting, we try and write an editorial summarising what we were discussing. I think we're going to cite both of the editorials that we've done for this podcast so people can read what we're doing. We don't want to keep it a secret. That's a bad mistake. I'm not criticising anything that's been done in the past. What I'm simply saying is that in the modern era, telling people what you're doing and bringing them along is an important thing. So to have some broader discussion this year at the International Headache meeting in Sao Paulo in September 2025, We're going to have a workshop session where we set out the areas that we think are important and we invite feedback from the attendees. The feedback's going to take two forms. We're inviting members with proposals for change to the classification to submit to the committee secretary a one-page outline of the problem and the proposed solution with some appropriate supporting citations. And the committee secretary's email is specifically cited in this editorial 2 that I was referring to. And the committee is going to select the most developed proposals and invite the authors, if they're present at meeting, to present them to the workshop. We're also going to have an open mic session for comments from the floor where people can have at it, so to speak. We wouldn't guarantee that every person who gets up and has at it and criticises us will necessarily agree with them, but I think we would like to at least once a year give people the opportunity to see where we're headed and to point out logical errors that they might find in the direction, be part of the team, so to speak. So I invite people to take a look at the editorial. It'll be coming out in cephalalgia, and we'll put a link to it for the podcast. And Stefan Evers is the current secretary. That's Evers, EVERSS, at uni-munster, munster.de. That will be on the editorial. And be kind when you write things. In the sense that there's no point sending a sermon on the Mount. We're interested in one page and not a sermon to Stefan, who will have enough to do collecting the one pages. Thanks.
No, I think that's a really great idea. I could even visualize something in the future like a crowdsourcing or some, comments, open comments online, and even other members could either support or say why that's not a good idea, kind of an open forum.
Yeah, it would help the case a lot if you've got something published or some sort of supportive literature, because one has to convince a lot of people that something is a good idea, and having some literature to start with is always a good place.
We did talk about this in a way about neurologists not being replaced, but maybe making our jobs easier, or especially for non-neurologists. What are your thoughts to AI, artificial intelligence, and the potential to help advance the classification, but in addition to that, better diagnose primary headache disorders or separate primary from secondary headache disorders, let's say in emergency room settings?
When given the language, the words that someone uses and their context, knowing where their background a little bit, demography, where they're presenting, and I mean that socioeconomically and demographically, be able to give some colour to the language that's used. I gave the not really example. And in different parts of the world, there'll be different ways that's said, and it will mean different things in different places. But I would hope that phraseology like that, in context that a large language model could decipher, would be able to give advice about what the person's actually trying to communicate with you. And in terms of primary and secondary headache, of course, checking tests, checking imaging, checking blood test results, because the machines don't get tired. They don't skip things. They don't jump over a line. If they're looking at something, they're going to look at it pixel by pixel. And they don't mind doing that till the cows come home. So I think that's picking up some of the drudge work so the clinician can better synthesize what the person said and what's been done in the emergency room to make sure that the treatment is optimal. And then, of course, you've got the sort of obvious thing when you're planning a treatment that the large language model should be able to relatively easily tell you whether there's any contraindications or odd things to expect with the current medicines the person's on and the medicine you propose. Because these model systems, from a factual pharmacy point of view, they can contain literally the pharmacological knowledge of the world and crunch it pretty quickly to make sure that we're doing things well, we're getting the right treatments, and we're getting the safest treatments.
Wow, well, you heard it on this podcast. The classification will support predictors of treatment response. You heard it right here.
Well, I'm an optimist.
Great. Well, thank you so much. This was a really great conversation. I learned a lot, and I look forward to the open discussion. And I know the neurologists listening, some of them are going to write those proposals and submit that. When will that be?
Well, we're going to put the editorial out in the next, as people are listening to this podcast, it'll be about the time they're listening or within a week or two of that. We'll make sure that the DOI is available at the podcast so you can keep a check on it, and we'll be happy to take take the submissions anytime you've got them written.
It's very exciting times. Thank you so much.
Thank you.
Be sure to listen to our full headache series and drop a comment. This is Tesha Monteith. Thank you for listening to the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.